Acute pericarditis has four principal diagnostic features. Number 1 is chest pain, which is usually present in acute infectious pericarditis, and in many of the forms presumed to be related to autoimmunity or of unknown cause. The pain of acute pericarditis is often severe, retrosternal, and or left precordial, and referred to the neck, arms, or left shoulder. Frequently the pain is pleuritic. Characteristically, pericardial pain may be intensified by lying supine and relieved by sitting up and leaning forward. Number 2 is pericardial friction rub, which is audible at some point in the illness in about 85% of patients with acute pericarditis. The rub may have up to 3 components per cardiac cycle and is described as rasping, scratching, or grating. It is heard most frequently at end expiration with the patient upright and leaning forward. Number 3 is ECG features, which we need to distinguish from acute ST elevation myocardial infarction. There are 4 major features of 12-lead electrocardiogram that distinguish ST segment elevation MI from acute pericarditis. The first is to look at the direction of the ST elevation. In acute pericarditis, the ST elevation tends to be of a concave upward variety, whereas in acute ST elevation MI the ST elevations tend to be of convex in nature. Secondly, which leads are involved. In acute pericarditis, most of the leads of the electrocardiogram will demonstrate ST elevation, with the notable exception of AVR. In acute ST elevation MI, those elevations are localized to the regions of infarcting territory, usually with reciprocal ST depressions in opposite leads. Thirdly is the nature of ST T-wave evolution. In the case of acute ST elevation MI, within hours of presentation, if no acute intervention is undertaken to reperfuse the vessel, the ST elevation becomes accompanied by T-wave inversions, and then later Q-wave development. In the case of acute pericarditis, there's also ST T-wave evolution, but it's much slower in nature. Over a period of days, the ST elevation returns to baseline, and only after doing so do the T-waves begin to invert, and they can stay inverted for weeks thereafter. The key point here is that if a patient presents with chest discomfort and ST elevation, and there is accompanying T-wave inversion, that's more likely to represent an acute ST elevation MI rather than pericarditis. And finally is to carefully see if there is PR segment deviations. PR segment depression particularly is seen in the majority of patients with acute pericarditis, but does not occur in patients with acute ST segment elevation MI. The number 4 diagnostic feature is pericardial effusion, which is usually associated with pain and or the ECG changes mentioned above, and, if the effusion is large, with electrical alternans. Pericardial effusion is especially important clinically when it develops within a relatively short time, because it may lead to cardiac tamponade. On physical examination, heart sounds may be fainter with large pericardial effusion. The friction rub and the apex impulse may disappear. The base of the left lung may be compressed by pericardial fluid, producing Ewart sign, a patch of dullness, increased fremitus, and egophony beneath the angle of the left scapula. The chest X-ray may show enlargement of the cardiac silhouette with a water bottle configuration, but may be normal in patients with small effusions. So acute pericarditis is a clinical syndrome, over 85% of which is due to a previous viral infection or on an idiopathic basis. This type of acute pericarditis is usually a self-limited illness. Even without intervention, patients would get better within 1 to 3 weeks, but there is more hastily improvement with medical therapy. What's important to recognize is that up to 30% of patients with acute pericarditis can experience recurrences within the next year. The first thing to address after diagnosis of acute pericarditis is to decide whether to admit or not to admit the patient to hospital. So, there are 5 main features that warrant admission to hospital. These includes: number 1, higher fever, greater than 38 degrees Celsius or 100.4 degrees Fahrenheit. Number 2, anticoagulation, with the concern being that acute therapy might contribute to bleeding within the pericardial sac. Number 3, immunocompromised patients where opportunistic infections may be playing a role. Number 4, patient presents with hemodynamic compromise such as hypotension, jugular venous distension, as a manifestation of right-sided heart failure, or a large pericardial effusion, these are signs that might indicate the potential for deterioration and tamponade. Number 5. The subacute onset of chest discomfort as opposed to fairly abrupt onset of pain, because this may represent a more chronic illness such as tuberculosis, neoplastic disease, or collagen vascular disorders. These all warrant admission to the hospital, but in the absence of these high-risk features, the majority of patients with acute pericarditis can be managed as outpatients. The medical therapies and approaches to acute pericarditis include 3 main categories. They include aspirin and other nonsteroidal anti-inflammatory drugs, the anti-inflammatory agent colchicine, and in some circumstances glucocorticoid therapy. Typically, nonsteroidal anti-inflammatory therapy is continued for about a 2-week course followed by a taper, and most patients will respond to this regimen. Colchicine acts as an anti-inflammatory drug, and the main primary mode of operation of colchicine is through inhibition of microtubule self-assembly within cells. So it reduces inflammation by interfering with functions such as neutrophil motility, which requires microtubules, phagocytosis of invading organisms, altered expression of cellular adhesion molecules at sites of inflammation, and by inhibiting mitosis by impairing cell division in G1 through impaired spindle formation. Glucocorticoids should not be used as primary therapy for pericarditis because these agents actually seem to increase the risk of recurrences. In addition, glucocorticoid therapy blunts the efficacy of colchicine in preventing recurrences. So, glucocorticoid therapy in pericarditis should be used only when patients are truly refractory to or intolerant of nonsteroidal anti-inflammatory drugs plus colchicine. If steroids do have to be used for a particular patient in pericarditis, the general approach is to use relatively lower doses and to taper this off very gradually, because too fast of a taper can result in recurrences.